All right, welcome. Let's begin your consultant Viva exam now.
Right. Here's your next case. Take a look at the initial presentation.
Okay, I'd approach this systematically. First, a really detailed history, then a focused physical exam. The main goal here is to get a handle on the pain, see what other symptoms are popping up, and sniff out any risk factors that could point me in the right direction.
So digging into the history, we have a 32-year-old man with this sudden, severe, sharp pain in his upper abdomen that's been getting worse over 12 hours. He's also been vomiting. Now, right away, a couple of massive red flags are waving at me. He's been taking ibuprofen, which is a huge risk factor for peptic ulcer disease, and he's a heavy smoker, which just adds fuel to that fire. Then you look at the exam. He just looks sick. He's got a fever, his heart's racing, and, this is the clincher, his abdomen is rigid with severe tenderness everywhere. You put that all together, and what you have are the textbook signs of generalized peritonitis. This is a surgical emergency, no question.
Okay, good. So based on what you found, what's on your mind? Give me your differential diagnosis, and I'm looking for a broad but relevant list here.
Okay, so let's break this down for a second. The key here isn't just rattling off the obvious stuff. Of course, a perforated peptic ulcer is at the very top of my list, and pancreatitis is right there with it. But including the big, scary vascular problems like a ruptured AA or an aortic dissection, or even a heart attack presenting a stomach pain, that's what really matters. Even if they're not as likely in a guy this young, it shows the examiner that you're thinking about the absolute can't-miss diagnoses. It proves you're a safe clinician.
All right, that's a solid list. Let's zero in on the most likely culprit. How are you going to confirm it? What are your immediate next steps?
So, my immediate plan has two parts, bloods and imaging. I'm ordering a full blood count, kidney and liver function tests, amylates to check the pancreas, and a clotting screen to get a baseline before we even think about surgery. And these results are telling. We've got a significant leukocytosis, a white count of 18, which is just screaming inflammation or infection. The other labs are okay for now. At the exact same time, I'm getting an erect chest x-ray.
And there it is. The chest x-ray gives us our answer. That's pneumoperitoneum, free air under the diaphragm. That is the classic textbook sign of a perforated hollow viscus. And with his history of NSAID use and that epigastric pain, I'm almost certain this is a perforated peptic ulcer. It's a surgical emergency, and we need to move now.
Correct. You've nailed the diagnosis. The patient is septic, they have a perforation. Walk me through your management plan step by step, starting right now.
My plan is all about resuscitating him and getting him ready for the definitive fix. So, first, we admit him, preferably somewhere we can watch him closely. I'm starting aggressive IV fluids to get his heart rate down and his blood pressure up. I'll get broad-spectrum antibiotics and even antifungals on board immediately, because this is definitely a polymicrobial peritonitis. Of course, we need to manage his pain and nausea. And while we're stabilizing him, I'll get informed consent for an urgent exploratory laparotomy. Surgery is the only real treatment here.
Okay, you're in the OR. You find a small perforation in the first part of the duodenum. The tissue around it looks inflamed, but otherwise it's pretty healthy. What's your surgical plan?
Okay, my goals here are simple. Control the contamination and fix the hole. So I'd start with a really generous peritoneal washout, using liters and liters of warm saline to clean out every corner of the abdomen. Once that's done, the go-to procedure here, for a stable patient with a duodenal ulcer, is a Graham patch repair. You basically just tack a healthy piece of omentum over the hole. It acts like a living, breathing Band-Aid, sealing the defect and helping it heal.
But just when you think you're in the clear, the story takes a turn. The initial surgery seems fine, but on day 4, things go wrong. This is a classic exam curveball designed to test how you handle things when the pressure's on.
All right, things are going downhill, fast. He's febrile again, his belly is tender, and his inflammatory markers are climbing. The patient is showing all the signs of recurrent sepsis. What do you do? Right now. The first thing that jumps into my head is a leak from the repair site. I'm ordering an urgent CT scan of the abdomen, and I'm making sure we use both IV and oral contrast. That oral contrast is absolutely key here. It'll light up the GI tract and show us exactly where things are leaking. And, well, the scan confirms our worst fears. There's a contrast leak and a collection. The first repair has failed.
Okay, so you try a drain, but he just keeps getting worse. You have to take him back to the operating room, and the findings are grim. The patch is gone, the hole is bigger, the tissue around it is inflamed and crumbly, and the patient is unstable. A simple re-repair is not an option. This is the ultimate test, the high-stakes bailout situation. What is your definitive plan now?
Look, in a situation this bad, with a sick patient and a hostile abdomen, trying another direct repair is just setting yourself up for another failure. We have to go into damage control mode. The goal is to divert everything away from that busted duodenum and give it a chance to heal. So I'd perform a pyloric exclusion with triple drainage. We suture the pylorus shut, create a bypass for the stomach, called a gastrojejunectomy, and then put in 3 tubes, one to decompress the stomach, one to drain the duodenum itself, and a third one further down to feed the patient. It's about controlling the source and diverting flow. That's the principle.
Excellent. That's a solid, safe plan for a real surgical nightmare. Now, one last question for you. Think all the way back to the beginning. What was the single biggest red flag that kicked off this whole mess? It was that ibuprofen, of course. Recognizing that link between NSAIDs and peptic ulcer disease isn't just about getting the diagnosis right, it's about preventing this from ever happening in the first place. That concludes this Viva.